So, welcome everyone to COVID-19 updates from Singapore. This is how we ad lib. This is because it's an outbreak, so we're used to filling in. I'm not sure what David's doing there, but we've got our usual lineup tonight. I'm actually in Darwin. I've done the haul down to Perth for my quarantine, and now I'm sitting here in Darwin, meeting up with some great people from the National Critical Care and Trauma Response Group here. And David, have we got you back yet?
Are you able to hear me now?
Oh, we can, and we can see you.
My apologies, everyone.
You're looking very concerned.
Yeah, a little technical glitch there. I don't know exactly what happened, but nevertheless, yep, Dale. So tell us, I heard your soliloquy, it was beautiful. Tell us what the experience was like being in isolation after you've, or in quarantine, excuse me, after you've mandated it for so long.
Well, no, I must say, as an ID physician, you do put a lot of people in isolation, and I tell you, I'll have a bit more empathy next time. Walking into a room knowing that you won't leave for 2 weeks is a little bit scary, but anyway, it has to be. You get better at it as the days go by. Every knock on the door for the next meal is a very exciting moment, and you can get supermarket deliveries, and I tell you, I was never bored. The work never goes away, David. So, yep, just like being in an office, except you can't leave.
Well, we're pleased you came out on this side of it mentally intact, the best we can tell.
Not affected at all.
Yeah. All right, Louisa, how are you tonight? Who will you be speaking with tonight?
I'm very well, and I'm very excited. We have a very special guest, Professor Lucille Blumberg. She's from South Africa. I'll be introducing much more of her later. But yeah, I am actually very excited to be speaking to her.
Great. Thank you so much. Okay, well, we'll open tonight's episode with Dale's epidemiology update, followed by the aforementioned discussion with Prof Blumberg that Louisa will have. And then we'll have the vaccine lightning round to follow that. Then Louisa will answer your questions that our audience members have been so kind to provide. Then we'll have the pandemic song of the month and a video from Dale's Secret Archives. And then that'll close out the evening. Just a reminder, please do submit your questions and topics to be addressed in next month's episode. We know we try to keep timely, so we pick those that are most relevant to what's going on at the time. There's a link you'll find in the chat box. Alternatively, you can reply to the reminder emails that you get in between the episodes. So without further ado, Dale, over to you.
Okay, so it's not good news, David. I think everyone would have been a bit more hopeful that things would be looking good there, but as you can see, the epi curves, which are still supplied on a regular basis from WHO for our benefit, you can see that actually numbers are higher than ever, and India is really the talking point. India and really it should be Brazil there as well, and we'll be talking a little bit about more those two in some depth. But if you look at just the frank numbers here with 295,000 cases from India in the last 24 hours. And 793 overall, we're looking at 37% of the world's cases that are identified are coming from India at the moment. And likewise, the deaths are almost 20%. So it's they're really struggling. Brazil is also taking its a lion's share of the deaths. You can see here, and clearly Brazil is overwhelmed. And we'll talk about that. So this is 8 consecutive weeks now. The numbers around the world have been increasing, and 5 weeks in a row the deaths have been increasing. So we've still got to figure this out at a global level. Here's the epidemic curves by WHO region, and I'll go through each of these in a little bit more depth. But you can see almost all of them spiking up for various reasons. So here's the Americas chart, and as always, US and Brazil have had the largest number of cases. if we look through these, you can see, well, I guess a scattering of the pink and the blue. The most important thing, I think, is to note that that Brazil, with this number of deaths per million population, is of the largest countries, is really outstripping things. And that's also, we must understand that when a country's overwhelmed, one of the other things that goes is its data. So these number of cases and the number of deaths would surely be underrepresentative of what they are. If we look at the epi curves, you can see, you know, this what I'd call an artifact. This is Brazil apparently flattening out, but US I'd regard as much more true to form, and that has obviously come down very nicely, both in terms of deaths and in numbers and in terms of deaths. So Brazil has now had a total of 14.1 million cases and 381,000 deaths. And they're still having 72,000 cases a day and over 3,000 deaths a day. And as I said, once you're overwhelmed, these would be an underestimate. So US has got similar numbers, about 65,000 cases a day, but just 876 deaths instead of 3,000 deaths. So even though the Brazil numbers are an underestimate, you can still see that once you're overwhelmed, this happens. And Brazil, there's easy to find reports that there's literally no beds, they're out of oxygen, the misinformation is at its worst. The P1 variant is doing them no favors, the leadership issues, the vaccine rollout. And once you get up to these sort of numbers, it's not a disease of the elderly anymore. It's and in fact, half the cases in ICU in March were under 40-year-olds. So that'll be partly because of the triaging, but even though younger people are less likely to get serious disease, if you get very large numbers of young people, then you still get good numbers of severe disease. So the European region, again, what's outstanding is the country missing here. So Turkey, France, Germany are really taking the lion's share. You can see there with 421,000 cases in Turkey over the last week. But, you know, by and large, fairly flat. We know this is largely due to lockdowns and those severe restrictions, but also vaccinations. So Europe is, by and large, sort of holding its own. But UK is not even on the first page. And if you remember, I think that was once second globally. Here it is over here on the second page with just 258 cases per million population in the past 7 days. So let me just go back. Here's 5,000, 3,000, 2,000 cases per million population, and likewise the deaths over here are 20s, 30s, 40s. As we come back here, UK 2.7. So they've really turned off the tap in the UK, and it's really quite exciting. Hopefully that sort of heralds the future for the rest of us. You can see in fact, what both Israel have done in terms of their case numbers, sort of really right down from these peaks of 10,000, instead of pushing 100 deaths. They're really, you can count them on one hand now, and UK similarly. So Israel, I think about 59% have had their first jab, and 55% have completed. And yesterday they had 135 new cases and just one death, when altogether they've had over 6,000 deaths. UK about 49% vaccinated, and yesterday had 2,400 cases and 22 deaths, whereas in the past they've had 127,000 deaths. So it's really remarkable to see. It's kind of the hope, I think, for all of us. Okay, let's go to Southeast Asia, where, as I said, India is the big story. Look at this, 295,000 cases in the last 24-hour period. So let's look across this, and you can see in 7 days, 1.7 million cases. That's 200,000 to 300,000 cases a day. They've had 16 million altogether for about 184,000 deaths. So what they experienced was that their numbers were falling since September, and then they had mass vaccination coming in. So clearly people eased off, the mask wearing, the social distancing eased, and then came these sort of super spreading events, the huge religious gatherings, political events, weddings, cricket matches, and now what you can see, from this this little chart here is that it's at its worst ever. There's again many examples: no beds, no ventilators, no oxygen. The test positivity rates at 15%. Many labs are closing because they're overwhelmed. There's stories of ambulances at crematoriums with 6 bodies on the inside, queues in hospitals, ambulances driving around looking for places to go. So it's hospitals that will take them. It's really dire. And remember, this is an average. So this is over the whole country. In some places, it will be a lot worse, where there's like a township that's getting particularly overwhelmed. So, our hearts really have to go out. And these are some of the Kumbh Mela, which is this Hindu pilgrimage, if you like. It runs on a 12-year cycle and goes to riverbank sites where people cleanse. And this year it's in Haridwar in Uttarakhand, if that's how to say it. I can feel the emails coming in now. So they've tried to do good things here. It's obviously a very important festival, but they're asking for PCRs in the 72 hours prior. They've shortened the length of the ceremony. They've discouraged people that are over 65 and other vulnerable groups. So really, it's very challenging in this environment. They've also got new variants appearing. With the E484K mutation from the South African variant, and also the P1. So this is a bit of a space to watch. Can this sort of massive transmission create new variants? We know it already is with the Indian mutations, but throw into the mix the Brazilian and South African variants. This is as I say, this is something to watch. So one of the flow-on effects from this is people coming from India. There's certainly reports of big plane loads of positive people coming from Hong Kong, Singapore, Australia, and there's already restrictions being put on how many people can return from India to that country, often where they're a citizen. By the way, India won the tests. And the T20 and the one-day series. So I guess you've got to have some good news. The Eastern Mediterranean, not a lot to report from here. It's the same countries: Iran, Iraq, other major ones with new cases, and you can see the trend in many of these countries is still upward in cases and also deaths. So I'll just skim over that one. We'll hear a lot more about the African region, or at least South Africa, when we talk to Lucille. But here's South Africa, quite a low number of cases in the last week, just 142 in the last 7 days, and quite a low death rate per million population. So probably some good things happening we're going to hear about from Africa. Just moving on now to where we are in the Western Pacific. And again, you can see Philippines again leading the way, Japan on the way back up, and in fact several countries on the way up, leading to this, what is our biggest spike in Wipro so far. Lots of red, and I guess if you've got low numbers the whole time, eventually these things have to go red. And I'll show you a few countries that really are just the outbreak's gone on too long. And if it was a one-year outbreak, it would have been heroic stories. But here's Japan cases. Let's just follow this. So there's, if you like talking about waves, this is probably the best national curve. Then a bigger wave, then a bigger wave. So, you know, if the trend is true, the Japanese are very scared about this. They've got some difficulties with, you know, the legal capacity to do restrictions. They introduce states of emergency, and they're thinking of doing that again now, or they may have just started in Tokyo and Osaka, Hyogo and Kyoto, with some sort of restrictions, at least strongly requested. So Japan's up to about 4,000 cases a day now. They have about 40 deaths a day. So they've really got to do something down, especially with the Olympics around the corner. Here's just a few more of our nearest neighbours. And this is what I mean. Let's look at the Vietnam curve. They've done this very, as you know, aggressive, focal lockdown, mass testing, push back towards eradication. And you can see they've done that three or four times. And, you know, they've done it again. So well done, Vietnam. You get cases and you manage with the community buy-in and the aggressive approach to keep bringing it down. Malaysia, unfortunately, is still, since their outbreak took off in the last quarter of last year, they've really struggled. A lot of focus on movement control orders and things like that, really limiting people from moving between states and within states. So that's what Malaysia looks like, and poor old Cambodia that hadn't had a death up until 5 or 6 weeks ago. They've obviously got some problems now, up to 500 or 600 cases a day, 59 deaths, as I say, all in the last 5 or 6 weeks. And here's Thailand. You'll remember when we described this, the origins of this outbreak very early on in the year, from some of the foreign worker population crossing the borders from Myanmar, and that is arguably how this was introduced, and now they're up over 1,500 cases a day. So Thailand doing it a little bit tough now with 48,000 cases total and 117 deaths. So, as I say, how would these countries look if it all stopped in September, October? They would have been the stars. So sadly, it didn't go that way. South Korea's got this incredible curve. They're just sitting on like 500 or 600 cases a day, not losing control, not bringing it completely down to nothing, but and they've only got like around 2 to 5 deaths a day. So they've got this sort of living with the virus harmony, but not going one way or the other. So if they can get away with that, then good. And we do know the South Korean people really buy into the restrictions and the movement limitations. And I'm pleased to say the last one, Hong Kong's obviously regained control with its sort of testing approach, which wasn't completely popular, but nonetheless they've brought it right back down. Singapore, we've got the dorm residents. You can see they're up from 511 to 513. Community cases up 11, 2331 to 2342. But a lot of these were, or 4 of these were isolated before detection, and 7 through surveillance. And the vast majority, of course, are around 300 of those over that 2-week period are all imported. I must say, I thought of you, Louise. I'm pretty sure this was one of your oh no, not the Woodlands one. Anyway, Westlight Papan was one of Louisa's dorms, but this is news today, I think, with 11. So there was a vaccinated foreign worker, got symptoms, was diagnosed, and now 11 of his contacts are positive. So there's a lot of obvious efforts going into isolating all the contact now, and not allowing what to to see what happened last April. And here's our cases: massive numbers, up to 30, 40 a day of imported cases, a smattering of community, but there'll be a little blip here after this is updated by tomorrow. And cases in the country, 1 in ICU, still 30 deaths, none in the last 6 weeks. General wards have got a smattering of patients. The care facilities are managing to stay open with 200 cases, and that's about it for this month, David. Thanks.
Great, Dale. Thanks so much. It's interesting. Turkey is on the uptrend, and its vaccination rate's about 24% so far. So it just goes to show you that continuing the social hygiene, distancing, mask wearing, et cetera, is important. Certainly, that would that's an interesting occurrence there. So, Louisa, please, over to you.
Yes, thank you. So it's really my great pleasure and honor to introduce our guest for tonight, Professor Lucille Blumberg. She's a Deputy Director at the National Institute for Communicable Diseases, NICD, of the National Health Laboratory Service in South Africa. So she's also the founding head of the Division of Public Health Surveillance and Response. She's currently medical consultant to Division for Outbreak Preparedness and Response, and also to the Center for Emerging Zoonotic and Parasitic Diseases. And she has worked on a number of outbreaks, including rabies, avian influenza, cholera, typhoid, and the Luho virus, which is the second African hemorrhagic virus that was discovered after Lassa fever. Professor Lucille established the Laboratory Surveillance Program for the 2010 FIFA World Cup in South Africa and set up the Mass Gatherings Unit at the NICD, which became part of the WHO Mass Gatherings Global Network. She's also been an advisor on the prevention, detection, and response to communicable disease risks to a number of African countries hosting large international gatherings. So Professor Lucille, a very warm welcome onto our show.
Thank you very much, Louisa, and greetings from South Africa. I wish I was in Singapore, had lots of great visits, but in the meantime, I invite everyone to come and visit us and enjoy some of the wildlife.
There's a lot I'm hoping to ask you tonight, so I'm going to dive right in. And it's unavoidable that with your background, the first question I'm going to ask will be on the South African variant, B1351. So what's in the headlines that we see? It's usually more transmissible, decreases the efficacy of certain vaccines, some much more than others. So what's your feel on this on the ground from the local data that you have?
So the new variant, and rather not call it the South African variant, it's a label that is difficult to manage. But it emerged in, it's okay, it emerged in October, November last year. And while we had been doing quite a lot of sequencing of isolates from infected people, it was noticed that the number of cases in one of our provinces, the Eastern Cape province, which has quite a poor infrastructure, had suddenly gone through the roof. So patients appeared to be younger, hospitals were overwhelmed, and some people alerted to the concern, and a lot more sequencing was done, and this new variant was identified, the number of different mutations. So we do think it is more transmissible. Patients seem to have higher viral loads. I think we're unsure about it causing more severe illness. I think when you get a huge wave, your hospitals, your health facilities get overwhelmed. So patients may be admitted quite late, and Dale spoke about problems in India with ambulances lining up, and the care isn't optimal. So it's difficult to say whether it did cause more severe illness. It affected the same group. It was not a younger group. It wasn't those without comorbidities. The risk factors remained the same. So it's the dominant variant, it's the dominant SARS-CoV-2 circulating in the country at the moment. And we have exported it to a number of countries, both in the region and I guess through travelers to a number of countries in the world.
And apart from B1351, were there any other more unique clusters that South Africa had, and how did you manage those?
So we did have some interesting clusters, and one of the first incidents in the second wave related to something we call a student rage. At the end of formal schooling, the young people gather together in different parts of the country over a week, and they attend parties, and it's best not to know all the things that they do. But there was one, a very large one, of about 1,400 attendees who gathered in a small town just outside Durban in KwaZulu-Natal. They obviously didn't conform with the regulations for masking and how do you socially distance at a social event of young people. I guess there were a number of asymptomatic ones or minimally symptomatic, or those who simply went along because they'd paid for it long in advance. They'd had what they called a tough year and they were going to go anyway. And there was talk about cancelling the event, but the organisers said, well, it would have gone ahead as an informal gathering anyway, because the students were determined. And there were large numbers who attended, who got infected. And it's not surprising given the close relationship between many of them. They brought it home to various provinces, most of it to Johannesburg, where I am, and passed it on to relatives, some of whom got severe disease and some of whom required admission and some of whom died. So that was an interesting cluster. All subsequent rages were banned and weren't allowed to happen. But, we have some interesting clusters. We have a lot of mining. Mines were closed for a time during lockdown, but when miners came back from very different areas, they do have very close contact. There were some increases in cases. We had a pub in Cape Town that offered half-price drinks to students, and of course they gathered in large numbers, and we had about 97 cases or so in the attendees there. So there's always something interesting. We had a group going to Antarctic. They quarantined them before the trip. Some of them still managed to have some contact, and there was a small cluster there. But I have to say, they did a bit more quarantine, and off they went safely to the South African station in the Antarctic. Something new and interesting every day, unfortunately.
It's very interesting indeed compared to, I think, what I've seen so far locally, even though we can draw maybe some parallels with the miners and our migrant workers here. But yeah. I'm also very curious about, the infrastructure or the healthcare system, albeit the economical system in South Africa, and how are some of those unique challenges faced and handled?
Yeah, so we've had very strong leadership from the top, from President. I think the Minister of Health has had the toughest job in the country, and I think he's done pretty well. But we have major economic challenges and a lot of inequality in terms of housing, a lot of unemployed people. So when the lockdown came, it really devastated the economy. So I think the subsequent interventions have been to try and open up the economy. Many countries waited until the cases were right down before they opened up their lockdowns. That couldn't be done here. We had to open up earlier. I think we're still experiencing and will for many years the devastating effect on the economy. We also need to remember that many people live in multiple people households. Houses can be very small, 10 people in a 1 or 2 roomed, kind of quite informal house. Is not unusual in many areas. So social distancing, isolation of people who don't require hospitalization, has been quite a challenge. And that's something we still need to deal with.
And Professor Lucille, what has been the role of the National Institute for Communicable Diseases? And you mentioned that you had a very supportive government, but I'm curious if you're able to share more on what was the NICD's particular relationship with the government.
Yeah, so we're essentially the Public Health Institute. When COVID started, we set up the diagnostic tests at the NICD. So all tests were referred here, and then it was deployed to private laboratories, very large private network, and also to the National Health Laboratory Service. So that was our first role. We've done a lot of the sequencing and a lot of the research around how effective the vaccines are. Our role is essentially a surveillance one. We collect the daily cases. They're all reported through to the NICD, so we can see areas affected, age groups, where the problems are. And we also established the hospital surveillance system, DATCOV, to get more information on hospitalized patients. You know, what did the disease look like in South Africa? Were HIV patients particularly affected? Actually, they aren't. They have a only modest increase in severity. And it's the usual comorbidity that's been identified elsewhere: diabetes, obesity, hypertension, older patients. So I think that was a very important finding, that HIV patients were not very affected by COVID.
And actually, my next question actually follows on perfectly from here. So we know that COVID-19, as you mentioned, is not only devastating in itself, it's also causing severe disruptions to the healthcare systems, including access to care, and has resulted in a multitude of complications in other chronic medical conditions, and also surges in other infections. So specifically for South Africa, has there been excessive morbidity or mortality from other prevalent infectious diseases?
You're absolutely correct. Hospitals were overwhelmed. They were essentially admitting COVID patients. They did very well with them. I think we had the benefit of what worked in other countries: dexamethasone, high-flow oxygen, which is affordable, but they really dealt with COVID. So patients who had chronic non-communicable diseases didn't get their medication. And of course, HIV, TB, and to some extent, the malaria programs were affected. And we're still counting the costs there. Hospitals are back to functioning at a reasonable level. We're between waves, not really sure what will come, but we've paid a big price for our big communicable disease programs and problems, particularly HIV and TB care, diagnostics and treatments.
So I think apart from communicable diseases, the world is really going to face a big challenge in handling all the non-communicable diseases, you know, that have, or patients who have suffered as a result of not getting healthcare in this time. Now, I'd just like to move on to another topic, Professor Lucille, and we can't miss out on this opportunity, given your incredible expertise in advising for mass gathering events, to ask you about your opinion on two upcoming major events internationally. And these are happening in quite close succession of one another over July to August in 2021. And this is the Hajj as well as the Summer Olympics. So in your opinion, is it too soon to allow these large international mass gatherings, and can they be held safely to any degree?
You know, I've been involved with mass gatherings held during Ebola outbreaks in Africa. But that's a very different kind of infection. It's not respiratory transmitted. You don't have asymptomatic people. And they all went very well. Measures were put in place to prevent and to respond. I think COVID is very different. Asymptomatic respiratory transmission, probably, you know, airborne to some extent. I really would love to see the games go on, the Olympic Games. I think I did see Dale's increase in numbers. I think there have been many considerations about how to make it safe, reduce spectators. A lot of it is outside. Fresh air is the best thing you can do to reduce transmission of COVID. We do have vaccines now, and I believe all attendees will be vaccinated. We do have some rapid tests, but they do have some limitations. So I think with a lot of care, I think the Olympic Games, and it's a cautious yes, may well be able to be held safely. I am watching that graph going up. I think the journey to Japan is you know, it's quite difficult for people. It's I think they'll have to make a decision in the next month or so. And I'm sure there'll be many discussions. The Hajj, I think they've put many interventions. They're used to managing mass gatherings. They've restricted entry and limited to nationals. I saw the pictures of pilgrims attending the events. There is social distancing. I think they've reduced the numbers of at-risk people for severe illness. And I think vaccines, again, will really save lives, livelihoods, and allow us to some extent to open up these events. So, COVID's going to be with us for a long time, and we have to find a way of managing it. Hopefully the vaccines will lead that way. With the variants, I don't think we're still learning. It's not just about antibodies, it's about other immune responses that probably are there and help to prevent severe disease, even with the variants. Yeah, so it's a challenging time, but I hope we will get through this.
Professor Lucille, thank you so much for the wonderful insights that you've shared so far. It's really such a pleasure listening to you. And although I'm very reluctant to let you go, this is regrettably as much time as we have on the show tonight. Before that, though, would you have any advice or just general, just anything general you wanted to, let anyone who's dealing with the pandemic know and just say before we let you go?
So I always say, save yourself first, otherwise you can't save anybody else. Keep calm, follow the rules, and work together with the team. We've been through previous pandemics, but there's nothing, unfortunately, like COVID. I think let it be science-based. I think that whatever evidence comes from science is the best one, is the best way to go. But we need to move faster and to prevent these in future. I hope the world never has to face a pandemic like COVID again.
Yes,
so I don't know if that's good advice, but those are some.
Definitely is our sentiments, exactly. So thank you so much again, Professor Lucille, and I really hope to cross paths with you once again in the future.
Thanks, Lucille. Really appreciate it.
Thank you.
Thank you.
Thanks, Dale.
So now I'll hand the time to Prof. David for his vaccines update segment.
Thank you, Louisa. All right, let's jump in. Let me share my screen if I can. So okay. Let's get started. I'm excited. I'm starting before 8 o'clock tonight. So this is a biggie for me. I may just expand now that I have the opportunity. This isn't particularly about vaccine, this particular slide, but I thought it was noteworthy. I'm sure many of you have seen this. This was the mission from a WHO mission looking at the origins of the virus. And there were 4 theories brought forward. One, that the bat transmitted it to an intermediate animal, which then infected humans. And then the notion that bat directly infected humans, or virus from an animal spread through a shipment of cold frozen food, or there was laboratory escape. And you can see over here to the right, let me get my presenter options. The notion that that this group, what their findings were, whether it was likely or extremely unlikely. But I think it's summed up by the DG of WHO, who basically said, not all the information is available yet. No conclusions can be reached. We need more information. So that's interesting. Let's get back to vaccines, something that I'm a little more comfortable with. And this is an update of those vaccines that have been either approved or emergency utilization or in limited use. And you can see how they're being used in ASEAN. This list slowly increases the numbers, but the number of vaccines haven't really terribly increased. There are quite a few, though. Most countries have more than one option. These are the 2 with the arrow that we have available in Singapore. This vaccine, CoronaVac, is in Singapore, but is not yet been approved by HSA for use, as it needs to meet quality, efficacy, and safety. Information is still forthcoming, but it is in use in the region. There's a new vaccine on the list this month. This is from from Russia. It is a inactivated virus, and we'll just keep track of that as well. Novavax is yet to be approved. Everybody's waiting for the shoe to drop, as that'll be one of the first protein subunit vaccines that's that phase 3 data is available. Okay, these are the doses given as of yesterday, 925 million. That's just a huge number, but obviously the world's population is 7.6 million. And you can see Israel, as mentioned by the others, one dose 59%, two dose 55%, so they've been very good about getting everybody vaccinated. And in Singapore, we have 24% of the population has received one dose. This data is a little bit old. And as mentioned, Japan having a surge, yet vaccination is still kind of low. In the region, Malaysia and Vietnam, you can see their numbers. I want to point this out. This is the reason between difference in UK. The reason why they're fully vaccinated is much lower than their given one dose is because their emphasis has been getting as much vaccine into as many people as possible, at least one dose. So that's why there's such a difference here, whereas in Israel and most of the places, it's a much closer item. Over here in this middle table is just a graph of it's just a graph of the percentage of people who have received at least one dose in the various continents. And you can see Africa is relatively at the bottom here, and Europe and North America is higher. America has, US has had 40% get one dose and 26% two dose. The reason this number is lower, Mexico and Canada are behind. Just to reemphasize the impact of vaccination experience in Israel, this just shows the number of cases that have occurred. In those who haven't been vaccinated, they had 388,000. Those who had one dose, this is less than 14 days or greater than 14 days. It's this number 66,000. Those who've had two doses, you can see as you've gotten your second dose greater than 14 days out, the number gets incredibly small. In our part of the world, it's increasing. This is becoming darker in color as time goes on, which is encouraging, which means that there's more doses per 100 people given, more vaccine given. And this obviously has implications for ring safety. Those who can't be vaccinated, they may be protected by those of us who are vaccinated. Implications for travel, commerce, leisure, and culture, as we all know. So let's get to the specific, some of the points. There should be or will be expanding groups that can be vaccinated. There's a nice article that just came out yesterday in New England Journal looking at preliminary findings for those who are pregnant who are vaccinated. And basically they found no safety signals, meaning it looks to be no adverse outcomes to the pregnancy or to the fetus or to the neonate. And they have in other studies, not this study, measured protective antibody both in the neonate getting through the placenta, as well as if you get infected, you have IgA in the breast milk after about 10 to 14 days. And if you get vaccinated, you have IgG predominant in the breast milk. So they get protection via the placenta if you get vaccinated and through breast milk. So it's a nice thing for the neonates. As far as kids go, children, Pfizer press release, this is phase 3 data. They said that there was 100% effective in this age group. They're subsequently doing cohorts from 6 months to 2 years, 2 years to 5 years, 5 years to 10 or 12, to 12 years. So that information should allow decisions to be made to expand vaccination into children here in the next quarter or so. As far as immunocompromised hosts, the information is not quite as reassuring. Solid organ transplant patients have decreased antibody in response to vaccine compared to those who are not vaccinated, predominantly due to antimetabolite agents such as mycophenolate and methotrexate. Renal dialysis patients have slower and lower antibody levels, and those who are on immunosuppression for inflammatory diseases, depending on the drugs being used, they have decreased levels of antibody, neutralizing antibody. Let's just talk about the variants of concern just a bit. The initial variant was the transition from D614 to G614. That occurred early in 2020, and subsequently we've seen, and it's taken over obviously, and subsequently we've seen these various variants, with a number of mutations. And the reason I put this up is not to bore you with these, other than to show you that these are independently evolving variants, and yet they have some consistent mutations. So I'm going to speak in a minute about evolutionary convergence, and that's what this is all about. B1617, which has been described in India, has two of these interesting mutations. One of them is the E484K, and the other is found in the California variants. So this theory of convergent evolution, it's basically that there are only a certain number of mutations that can occur that will benefit the virus. And so the feeling is, because of all these particular mutations that I showed in the last slide are occurring spontaneously and allowing them to predominate in the areas where they are, it's because those are the only mutations that are really make it more efficacious, more viable, more easily transmitted, in some cases potentially more lethal. So these are some of these mutations that we see over and over in these variants of concern. The limitation of this theory is it's really challenging to predict the impact of several simultaneous novel mutations. So there may be some different mutations that occur at the same time that may be able to give a similar effect by the way they impact either binding or a neutralization. So that is yet to be seen. But if the theory is accurate, if indeed there are only a fixed number of mutations and we're seeing all that there are, then maybe we only need one or two more vaccine iterations to be able to get this thing completely resolved. Let's talk a little bit about this. Now, I do want to emphasize the data is not directly comparable. These studies are different kinds of studies done in different populations, measuring different endpoints. You cannot compare and contrast across. So please do not take this information out of context. It's a compilation of public statements, press releases, preprints, modeling, and so you need to interpret this with caution. But nevertheless, it's handy to see it in a table just to get a sense. So the parts that I'm going to just speak to briefly are those things that are in red. Some of them are interesting, and some of them are useful. The folks that are, the press release from Gamaleya said, in fact, more recently that against the original strain, that the vaccine's 97.6. This is Sputnik 5. They also said against the UK strain, didn't provide any data other than to say it was the best at neutralizing. So that's very reassuring. There was some data that has been presented that against a B1351 that actually had no neutralizing activity. That has not been printed yet, or excuse me, that has not been peer reviewed. We'll wait to see that. As far as the Pfizer-BioNTech against South African, the B1351, which was initially identified in South Africa, that they reported by press release that it was 100% efficacious. However, there's a preprint from Israel that suggests that there's breakthrough infections, albeit in very few cases. So it's a little difficult. Somewhere in between is likely the truth. As far as the P1, which was originally identified in Brazil, you can see a decrease in neutralizing antibody, but from vaccinated people with the J&J, there was a 68% efficacy, and for the Sinovac, the Coronavac vaccine, they reported a 50% efficacy where there was a large amount of P1 circulating. Again, this is the California strain. These are the 5 variants of concern. There are other variants of interest, but these are the variants of concern. Just to show you, reassure you that this is the reported efficacy at preventing preventing infection altogether. So in theory, these folks are not able to transmit virus to others. So that's very encouraging, but it's not 100%. So therefore we need to continue to wear masks and socially distance. This is the data from the AstraZeneca, the Oxford vaccine, and this is the available data from J&J. This stuff is all relatively preliminary. The interesting thing was even those who were asymptomatically infected that received the Oxford AstraZeneca vaccine, the duration of shedding and the viral load was much less. So it may be low enough to where they're not infectious or be able to transmit to others. So there's a lot of reasons for using a different, or potential reasons put forward for using a different vaccine for the second dose. It's because of concerns about potential adverse events, which I'll mention in a moment, limited availability of vaccine, or there's concerns potentially about efficacy. So the rationale is enhancing the immune response and to address these issues. There are specific registered trials underway, phase 3 trials looking at giving the Pfizer vaccine as the first dose and the AstraZeneca as the second. We've spoken of this before, and we've spoken of the Sputnik 5 being an adenovirus followed by AstraZeneca. It's a chimpanzee adenovirus vector as trials underway. There are also plans for other ways of mixing these vaccines. There's a UK trial getting started that's going to follow the AstraZeneca vaccine with a Novavax or a Moderna. And then not for trial purposes, but because of what's gone on with the AstraZeneca concerns, in France and Germany, if your first dose was AstraZeneca, then your second dose will be with an mRNA vaccine. There's a mention from Dr. Gao Fu, who's head of China CDC and prevention, who last weekend did mention possible mixing because of concerns about efficacy. Subsequently, the statement came out that he may have been misinterpreted. I'll wait for additional information. As far as those that have infection after vaccination, the criteria of what is a new infection is somewhat can be debated, and it is important, but it has not been standardized. In the US, CDC reported this week that there's been 5,800 cases and 77 fully vaccinated people for this rate. Morbidity occurred. They say that 1,700 were asymptomatic, but it's likely underdetected. This is likely a much larger number that got infected, and this is a much larger component of that. What they're trying to sort out now in the CDC in the US is the variants of concern and variants of interest and what impact they may be having on these 5,800 cases. So in order to try to address this issue of standardization of what is a reinfection as opposed to a continuing to shed continuing to shed virus, the European surveillance system, so-called TESI, is proposing what might be. And you can, there's arguments why this is incomplete or inadequate, but it's a step forward. They're just trying to get consensus in the European Union and in the European economic area. To get that addressed. So the issue that has disrupted use of AstraZeneca vaccine has been this concern about clotting, whether it's the syndrome is venous and arterial clotting with moderate to severe thrombocytopenia and a lysopositive antibody to platelet factor 4 heparin complex. And they show up most concerned fashion as cerebral venous sinus thrombosis, CVST, which is about 60% of them, but also in other areas of the body, splenic bed to the gut and limbs. They're occurring, best data suggests 39 per million with COVID-19. That's the infection, not the vaccine, and only 5 per million after the vaccine, if indeed this is the etiology. And there's a 20% mortality regardless of whether it's the vaccine or the infection triggers it. But again, obviously this is 7 times difference. So avoiding the vaccine and getting the infection is no bargain. Initially, it was thought to be women more than men, but women more than men. But when it was adjusted for the fact that more women were vaccinated because more women were healthcare workers, it looks to be about equal distribution. They're young, and symptoms begin at this time, and we're really unable to predict. J&J has also had 8 cases. These are both adenovirus vector vaccines, and this is one of 2 articles that appeared in New England Journal last week. Just to put this risk of thrombosis into context, so it's 4 cases per million or 5 cases per million. Birth control pill, about 1,000 cases per million. Smoking, and then the actual infection itself. So it's clear that the vaccine is this is a minor point. However, it has gotten everyone's attention, so it's been stratified. The risk of clotting due to the vaccine, potentially, if it is indeed the trigger, is higher the younger you are, and it gets less the older you are. The risk of severe illness with COVID-19 in an area where there's very little exposure risk, 2 per 10,000 per day, which is what it was like in UK just last month, then clearly the damage from the infection far exceeds the damage from the potential damage from the vaccine. And even here, it's an awfully close match. So that's why the UK is no longer giving the vaccine to those under 30. But those others over 30, it clearly makes a difference. Then the rest of the world with transmission is higher. In every age group, it makes sense to give the vaccine. It is clearly in the favor of the vaccine. So what have been the country's response to this association? If they've not begun the series, these countries are saying use a different vaccine. In the UK, they're saying if you're less than 30. In South Korea, likewise. In Australia, less than 50, et cetera. The Philippines has gone back and said, no, we're going to give it to everybody after analysis of the data. If the first dose of AstraZeneca has been given in Germany and France, depending on your age, they'll give you a different vaccine, which is an mRNA vaccine in those countries. Denmark has just said enough. We're going to find an alternative. They're using mRNA vaccines and not bothering with AstraZeneca. So this is just an interesting issue that's come up, and that's how to manage and communicating risk. Because clearly, giving the vaccine is far better than letting people, putting people at risk for getting infected. So this is the old trolley problem that we all learned about and debated in university, where you've got a trolley on a track, you cannot stop it, and there are 5 people on the track, and you're going to kill them. They're going to die if you do nothing. But if you do something, if it by your hand you change the trolley so that it goes down this track, it kills 1 person. So you passively allow 5 people to die or actively kill 1 person or participate in the death in that 1 person. So this is what advisory bodies face. That's the first question they have, and it's very easy. You give the vaccine, fewer people die, but you're giving a vaccine that has potentially a risk of causing morbidity and death in a small, very, very small number of people. That's tricky communicating, and that's what all of this is that we hear about, is the effort to try to put into perspective, communicate, and manage that risk tolerance of individuals, of countries, of societies, et cetera. The problem has been is there's differing messengers. There's individual national health authorities, there are individual countries' national health authorities, there's individual nation leadership, and there's multilateral health organizations. They all have their own agendas, appropriately so, but they are often differing. So you can see that some countries are saying, never mind, we're moving ahead. So other countries are saying we're avoiding altogether. And I think it leads to, it's just difficulty managing that, but manage we must. So this is my last slide. What are the future SARS-CoV-2 vaccines? There's probably going to, well, they're already in the works, a mixture of mRNA vaccines or mRNAs going into a single vaccine representing the different variants and possibly different targets other than just the receptor binding protein on the S spike. It may be other things that are important. And I think there's some data coming out that's suggesting non-neutralizing antibodies may have an important impact in controlling disease as well as neutralizing antibodies preventing disease. There's already underway trials using nasal vaccines in Hong Kong. I know there's a phase 1 trial going on, and there's other work going on in oral and inhaled vaccines as well. There's a very cool concept vaccine in the works called, it's using a different viral vector. It's using, instead of adenovirus, it's using Newcastle disease virus vector. It has 6-proline spike protein substitution. This helps keep it in a pre-fusion conformation, the S protein, the spike protein, which is valuable. But it can be grown in eggs, and a lot of countries have egg vaccine manufacturing for influenza. So this is very cheap. So we're using eggs, we're going to make it, and it doesn't require some of the extreme refrigeration that some have required in the past. So this is going to be an interesting concept, how that evolves. It'll be very, very inexpensive. And obviously there's work going on pan-coronavirus vaccines that might be effective versus MERS and SARS and SARS-CoV-2, et cetera. The National Institute of Allergy and Infectious Diseases in the US is soliciting proposals, and CEPI, who's CEO we had on last month, Richard Hatchett, they are happy to fund this kind of work, and I know there's work going on. So that's it for vaccines this month. Over to you, Louisa.
Okay, so before I do my Q&A, I have a very fast flash update on B1617, and it's not called the Indian variant. I broke my own rule just now. Shall all ignore that. So this particular variant has been called a double mutant, and why is that? It's true that it has 2 spike protein mutations, but in fact, actually, it contains a total of 13 amino acid changes. So speaking of spike protein mutations as well, actually, B117, B1351, and P1, they all have 8 to 10 each. So really, this double mutant is just a name game, I think, and it doesn't carry any scientific weightage. So just to get that out of the way first. But out of the 2 spike protein mutations that have occurred here, firstly, we have E484Q, and that sounds familiar because E484K is actually present in B1351 as well as P1. And they're actually K is lysine, and then what we have in the B1617 is actually Q, which is glutamine. So there is actually limited knowledge so far on E484Q in particular, but it has some concerns on immune escape. And it has been shown to reduce some neutralization for convalescent plasma from the blood plasma of recovered patients, but in an experimental laboratory setting. So the other spike mutation is L452R, and as Prof David said, this is also present in the variant that's from California. There's also some concerns with neutralization here, but it also has shown to have some reduced neutralization by convalescent plasma samples or certain monoclonal antibodies. But again, this was all in a laboratory setting. So I will talk about another particular mutation that is in B1617. And that is P618R. And this may also sound a bit familiar because P681H is present in B117. Now, this particular amino acid actually this particular amino acid change is actually located just next to a site of the spike protein called the furin cleavage site. And the furin cleavage site is of interest because it's quite unique to the SARS-CoV-2 virus. It's absent from some other common beta coronaviruses, and its function is actually to facilitate the entry of the virus into epithelial cells lining our respiratory system, and that means it helps the virus to enter our cells. But so this means a mutation in it could either alter spike protein processing or the biology. But I think there's still much mixed evidence so far on whether this particular mutation is actually favorable or detrimental to the SARS-CoV-2 virus. So overall, we can work much faster now, I think, to understand and study the properties of these various new variants of concern, of which B1617 obviously takes the spotlight for now. But even for this variant, it's still too early to tell what its true impact and trajectory will be without much more data. And for B1617, actually, what might actually be news to all of us is that it's not actually even new. So this actually dates back to early October last year, and that was when it was first uploaded onto GISAID. And prior to causing a massive crisis in India, it's actually made its way before that to the UK and the US. And compared to India, which is actually in the middle of completely opening up by around February, the UK was actually, as we know, in the midst of another major lockdown, again, because of B1617. So what's the real cause of the current situation in India? I think we can't ignore the variant, of course, but as we mentioned before, and I'll highlight again, such large outbreaks are really multifactorial, and they can't really be blamed on one single factor, including a variant. So our take home really is, without any frills, that the pandemic is still not over yet, and complacency is really not our friend. Okay, now I'll move on to my Q&A, and let me look for my questions. Okay. So we've once again received a large number of very interesting questions, thanks to the audience who sent them in. And again, I've bundled them into general themes. I won't be reading out all your names this time, but they will be flashed on the screen, so do keep a lookout. The first set of questions relates to variants. Some of them have been answered earlier by Prof. David, so I'll tackle the one on one other variant under investigation from France that appeared around mid-March. This was seemingly alarming news at that time because a small group of 8 to 10 patients had, despite displaying clear ARI symptoms, had multiple COVID PCR nasal swabs return negative. But actually, this isn't the first time that a variant was suspected to be able to evade testing. But it's important and reassuring to know that there are still a number of good tests, a large number of good tests on the around the world, good test kits. And even though they haven't been gaining much spotlight recently, they are still constantly being developed as well as upgraded. Also according to the variants. So now if anyone had tried to follow news of this French, I was going to say French variant again, but this variant under investigation, you will notice that it kind of just actually dropped off the radar after a few news reports. And prior to this, actually, there was another variant that had a very similar concern of evading testing. So why is this that, they didn't really gain much traction? I can think of a few good reasons. So firstly, even for some of these French patients, they still eventually received a confirmed positive diagnosis, and this is through collection of sputum or doing serology. And again, we know that actually, even with the normal COVID strain, so-called, a proportion of patients won't test positive simply because of lower viral loads in the nasopharyngeal cavity or swabbing techniques, amongst other factors. But we've never been exceptionally worried about needing to see a 100% positivity of testing of patients with COVID because clinical judgment and assessment actually always takes precedence. So testing is great for those without symptoms perhaps, but for those with symptoms and who are sicker especially, we won't dismiss the possibility of COVID just because the initial swabs came back positive. So even for myself, I've actually chased many cases for various different types of testing while still treating the patients as presumptively for COVID. And lastly, there has since been assurance that there is actually a European test kit that still works to test positively for this variant under investigation. And even for those test kits currently that might not, they can also be modified. So the second theme of questions is related to post-vaccination immunity and long-term side effects. And again, Prof. David has actually answered a bulk of this in his earlier segment. But the overall simple answer to this or message is that we're actually still waiting on a much more conclusive data, but do not wait to get vaccinated. Because long-term, we're talking about 10 years or more. There is already enough safety data and efficacy data from the now almost 1 billion people who have gotten vaccinated around the world. And when there's new safety monitoring concerns, we've clearly gotten to know about it. So this shouldn't be a reason to delay vaccination. Now, lastly, there's a few audience members who've asked about medical conditions and getting mRNA vaccines. So in Singapore, there are clear local guidelines for those who are considered severely immunocompromised. And these are patients who are either on active cancer treatment. Now, there's actually different types of cancer therapies, though, including immunotherapy, but I'm not going to be reading out the whole list. If you're really interested, this information is easily available on our MOH website. And these also include patients with within 3 months of a stem cell or organ transplant, as well as patients with a CD4 count of less than 200. But do take note that these are also risk stratifications that are particular to Singapore. And we've held off vaccination for this group of patients more because of concerns that the immune system may be too weak to mount a good response. And because they're usually undergoing quite intensive therapies, we don't want to further stress them with any vaccination side effects. And it's not really because we have any hard concrete data that they will experience any more serious side effects in getting the vaccine. So it's likely for them to be safe as well, but without clearer efficacy data from larger trials, we don't need to be in a hurry over here. So for everyone else who is on other types of immunosuppressants, including low-dose steroids, as long as your medical condition is stable, you're not in an acute flare, you can get the mRNA vaccines. But although, again, please note, I'm actually saying this as general advice, which will fit most. But if you still have a very specific concern for yourself or your family member, it's best to please ask your own doctor instead. So the last set of questions I'll summarize is how we're going actually with our local vaccination drive. And the answer is not badly at all. So we have, as of today morning, more than 2.2 million local residents who've gotten at least one dose of the vaccine, and almost 900,000 who have completed both doses. And there has been ongoing rigorous monitoring of safety as well as side effects since the very beginning of our vaccination rollout. And we've not really had any unpleasant or unexpected surprises since. So in fact, we're quite happy with the initial local data on allergic reactions, which was a major concern with the mRNA vaccines, such that a few weeks ago, our eligibility criteria for those with allergies could even be relaxed. So far, the rates of local allergic reactions are about twice that of the flu that's expected for the flu vaccination, but overall, that's still very, very rare. So again, no change in our message here, and I think that's what I'll leave you with tonight. Get vaccinated with what you have, and as soon as you can.
Thanks, Louisa. That was lovely. Dale, I'm going to give you the opportunity to introduce your video.
Yeah, thanks, Louisa. That was good, and thanks, David. It's we've gotten through another show. I'll be fumbling my way through Australia, doing more work over the next couple of weeks. I just wanted to give a quick shout out to Alison and Paul Effler, who looked after me so well in Perth, and just to talk about the video. It's a phenomenon, this Jerusalem thing, and I looked through it, and it's actually from South Africa. It was first came out in November 2019 by some singers, Master KG and Nomsibo Zikodi, and then in February 2020, to make it more uplifting, some Angolan friends put some dance steps to it, and then this turned into the Jerusalem Challenge, and it's uplifting, it's heartwarming. It's been done by policemen, army, newly married couples, and most particularly by healthcare workers. And I've just got a feeling it might be the COVID anthem for healthcare workers when we reflect back on this. So, Jerusalem, David.
All right, great, Dale. I want to thank Lucille and Louisa and Dale for sharing their individual and combined genius. It's helped to make another great episode. Just to remind everybody, next month's episode will be on the 27th of May at the usual time. Join us then. Don't forget to submit your questions and topics for us to consider in the chat box, which will be open after this episode closes, and it'll be at the bottom of your screen. Our pandemic song of the month is from Carole King, for all you old timers that might remember her. She wrote this song in 1992. It's called Now and Forever. It's a it's a song of hope, embracing that even though we may be apart, we'll always be together in spirit. It'll be followed by Dale's selected video. Until next month, stay safe, wear your mask, wash your hands, socially distance, and get vaccinated. And encourage your loved ones to get vaccinated. Thank you for watching, enjoy, and good night.
In addition to all of us being vulnerable to a little tiny virus, we're suffering from fear, hateful rhetoric, chaos, and uncertainty about food, school, where we're going to live, and how we're going to live. Please don't give up. It will get better. It will.
Now and forever, I will always be with you.
Jerusalema, ikhaya lami, ilondoloze, uhambe nami, zungangishilana. Jerusalema, ikhaya lami, ilondoloze, uhambe nami, zungangishilana. Dawo yami ayikholana, buso wami awukho. awukholana ilondoloze zuhambe nami dawo yami ayikholana buso wami awukholana ilondoloze zuhambe nami ilondoloze 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 zungangishilana ilondoloze 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 zungangishilana dawo yami ayikholana buso wami awukholana ilondoloze